and welcome to today's webinar on understanding and fighting Parkinson's motor symptoms. My name is Caitlin Garbett, and I am the Programs and Services Coordinator for Parkinson's Society Southwestern Ontario. And today it gives me the honor to introduce Dr. Camilla Aquino. We had her speak last year at one of our Living Well conferences in Cambridge, for those of you who attended. So it's great that we can have her back today to talk about this important subject, as many people experience many symptoms related to this. So to get started, we're going to introduce her. She is a neurologist from Brazil with fellowship training in movement disorders at the Toronto Western Hospital, University of Toronto, and she obtained both master's and PhD degree in neurosciences in Brazil, studying Parkinson's disease, and is currently training in evidence-based medicine at McMaster University in Hamilton, Ontario. She is a member of the International Movement Disorder Society and the Parkinson's Support Group. Her main areas of interest are Parkinson's disease, deep brain stimulation, clinical trials, and evidence-based medicine. Welcome, Dr. Aquino. We're so excited to have you. We can't wait to just hear what you have to say. And if anyone has any questions during the presentation, you can address them in the chat box below, where there's a symbol that looks like a question mark. And we'll answer those when she is done. So thank you, and continue.
Hi, good afternoon, everybody. Hi, Caitlin. Thank you for the kind introduction. So it's a pleasure for me to be here. So I hope, can you hear me well?
Yes, we can.
Okay, that's great. So I'm going to talk about the motor symptoms in Parkinson's disease. So the title of my talk is going to be Understanding and Fighting Parkinson's Motor Symptoms. So let me get this moving. Okay. So when James Parkinson first described Parkinson's disease in 1817 in London, that was his description of the disease. So he called it shaking palsy. And he used these exact words: involuntary tremulous motions with lessened muscular power in parts not in action, and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, and the sense and intellect being unaffected. So that was how he first described the disease. And basically, in this very short paragraph, he was able to summarize most of the motor symptoms that patients with Parkinson's present. And interestingly, many of these observations were made by people that he saw walking in the street, and that he was able to recognize that they had similar patterns of movements. So based on that, since the first descriptions, we know that Parkinson's disease motor symptoms are what we call bradykinesia, which means slowness of movement, tremor, rigidity or muscle stiffness, and postural instability. So to say someone has Parkinson's disease, we have to have bradykinesia. This is the most important symptom, which means slowness. And in addition to that, we need to have one of the other symptoms, either tremor or stiffness or the impaired balance. So that's how, when patients go to a doctor, we can say they have features of Parkinson's or Parkinsonism. So I would like to go in a little bit more details about these symptoms with you, and I'm going to show some videos that maybe for some of you will find familiar, or maybe you don't have the same symptoms, but it's important to know how we translate what we are talking about when we use these words to describe symptoms. So as I said, the slowness of movement or bradykiniesias are typically when patients report that the movements are either slow or smaller. This slowing is sometimes felt like a weakness, but actually it's not. The power is actually good, but the velocity, the speed of the movements are affected. So it's usually when patients start the movement, they can start rapid and bigger, but over time that's become difficult to maintain, and then they become slower and the movement is smaller. So let me show, for instance, this patient. So as you can see, when we ask her to do the finger tapping, we see that the movements, especially in the left hand, are very slow, and she's not able to keep the big taps. It reduces over time. The same happens with the hand movement as we ask her to open and close her hand really fast. So why this happens? So the bradykinesia happens because of the lack of dopamine. So in patients with Parkinson's, the cells that produce dopamine in the brain are reduced, and basically dopamine is like a fuel for the motor neurons. So it's like the gas that they need. So when the cells are affected, they do not produce dopamine, and therefore the patients start to become slower. So this can affect the hand function, can affect writing, can affect the gait, so they can walk slower, can affect the speech. So both the volume and the speed of the talk can be affected. The facial expression, because patients then start to present lack of facial movements and they have what we call masked face. But the good thing is that bradykinesia responds very well to most of the Parkinson's treatment. So the next symptom is the tremor or the shaking part. So shaking or trembling can affect the hand, the foot, the jaw, sometimes the tongue, and it tends to appear most of the time in the parts that are resting or sometimes on posture, but very rarely when the hand is actually being used. So usually not during the action. So exactly like James Parkinson's described initially. So it tends to stop when patients actually try to reach something unless the tremor is really severe. But not all patients with Parkinson's experience tremor, although this is one of the symptoms that people usually think when they talk about Parkinson's. So actually, a third of the patients with Parkinson's disease do not have tremor. So this is just to show how this tremor presents. So it's usually asymmetric. So one side tends to be more affected than the other side. And as you can see, the hands are resting, but when the patient holds the hand, it usually goes away for a little bit and then it can come back. So the exact reason of why patients develop the tremor is somewhat related as well to the dopamine deficiency, but is not as straightforward. Not all the times that you replace dopamine, the tremor goes away. Sometimes we need to use other types of medications to help with the tremor. But also some patients feel that when they are more anxious, when they are stressed, when they are sleep deprived, then the tremor is worse, and then relaxing strategies can help in those cases. So the next symptom is stiffness or rigidity. Rigidity or stiffness refers to a lack of flexibility in the muscles. Sometimes patients describe as tightness or tension, and it can affect arms, legs, the trunk, and the neck. So some patients report some pain associated with the stiffness because they cannot stretch themselves. They cannot feel their muscles relaxed. And this happens because in patients with Parkinson's, the muscles are not properly relaxed when they are at rest. So there is always a little bit of muscle activity going on. So this also happens because of the lack of dopamine in the brain, so the muscles cannot relax properly. So usually when patients with Parkinson's go to a doctor, we test them with the maneuver I'm going to show now, and we seek for some what we call cogwheel rigidity, as you can see here. It's not uncommon that people don't feel they are stiff, but then when we test, we actually can feel. So once again, this is a symptom that tends to respond well to dopamine replacement, but sometimes people have pain, so they can also use maybe Tylenol, ibuprofen, and other approaches just to relieve that pain in the muscle. In addition, other strategies such as stretching, massage, relaxation, and physical therapy can be helpful to relieve the stiffness. So one other symptom, as I mentioned, is the postural instability or the balance problems. So this usually refers to being unstable when you are standing upright. So in some patients, especially in the early phases of Parkinson's, this tends to be very mild. So people just feel they tend to stumble on the side sometimes. But over time, it can become more severe and increase the chances of having a fall. So this happens because the reflexes that are needed to keep the balance are affected in Parkinson's. So we usually recommend that balance training is one of the best approaches to keep, and not only to treat, but also to prevent balance problems. Some exercises like Tai Chi, yoga, dance, also exercise to strengthen the core muscles, to improve the strength, the core muscles, and also aerobic exercise like biking, swimming, can also help to keep and preserve the balance for as long as possible. In addition to the balance, another reason why patients sometimes may fall is because of freezing episodes, or what we call freezing of gait. Sometimes we call it just fog. Appears, and that's described as a person that feels as if their feet are glued on the floor while they try to walk. It often happens when patients start to walk, sometimes when they are crossing a doorway, sometimes going around of something, or sometimes making a turn. So not everybody presents with freezing in all those situations. For some patients, for instance, the doorway may be worse than turning. So it tends to last just for a few seconds and then it disappears. And most of the time after that, patients with Parkinson's can walk normally until they face again that situation that made them freeze. So this happens because in Parkinson's disease, the internal cues that are needed for walking are affected. So this has multiple causes, sometimes attention, sometimes cognition, and because that is affected, then patients tend to have this difficulty to initiate their gait. So once again, I'm going to show a video of a patient that had freezing of gait, especially while turning. And then he can walk normally. And then once again, to turn, he has difficulty again. So in addition to the freezing, some patients have what we call the fascination. So fascination are very rapid and small steps that patients present. So their body tend to lean forward and they kind of shift from walking to a small run. And that also predisposes them to fall as well as the freezing. So as I mentioned, both the balance and the freezing of gait are very complex problems because they are not directly related only to the dopamine deficiency. So that means they may sometimes not respond only to the dopaminergic therapy. So there are multiple pathways that are involved in attention, cognition, also the brainstem function and the cholinergic systems in the brain can be affected. So all that resulting in the risk of falls either through balance problems or for freezing of gait. And in some patients, treatments can also worsen that problem. For instance, patients receiving DBS may have worse balance problems than patients not receiving DBS. So there are some strategies that can be used for freezing. So one important thing is to avoid multitasking while walking. So for instance, I had a previous patient that every time she was carrying a cup of tea or a cup of coffee, she would freeze. But if she was not carrying anything, she was only focused on her gait, she would never freeze. So in that case, she knew what was causing, like the dual tasking in that case was causing her to freeze. So there are some tips that can be very helpful. So for instance, the use of visual help. Here, for instance, now there are these shoes that have a little laser point that draws like a line in the floor, and then patients can try to always walk stepping over that line. So that changes their attention and that helps them to overcome the freezing. So the focus on a visual target can be very helpful. So if people cannot have that, sometimes they can just have like a cane that has the same laser target, or even the walker, or sometimes just walking with someone that can put their foot in front of you so that you can jump over whenever you freeze. Also, listening to some sound, especially a rhythmic sound, can be helpful. So maybe having headphones with some kind of music, or just some type of rhythm. Or some patients say that if they just count, they start walking and counting 1, 2, 1, 2, 1, 2, or maybe 1, 2, 3, they can keep going without the freezing. So there are, as I said, sometimes patients respond to dopaminergic therapy, to Levodopa or dopamine agonists for their freezing and balance. But many times we need to use medications that work in different parts of the brain. So for instance, in cognition, in attention. And so there have been studies with drugs such as amantadine, donepezil, which is a cognitive enhancer, methylphenidate, which is the Ritalin that is used for people with ADHD, so droxidopa, atomoxetine, memantine. So other things can be used. And more recently, surgical interventions, for instance, deep brain stimulation, and very recently, spinal cord stimulation has been studied to improve freezing of gait in patients with Parkinson's. So, and how do we fight these motor symptoms? So I'm going to talk a little bit about the drugs, the options of drugs that we have to target these symptoms that we just discussed. So sometimes it is a little bit difficult for patients to understand the different mechanisms of the Parkinson's drugs. Well, to be quite honest, even for most of the doctors that are not neurologists, it can be difficult to understand. So here in this picture, we see, so this red thing here is the blood-brain barrier. So what is on the left, it's not in the brain yet. What is on the right is in the brain. So when we take Levodopa, so Levodopa is absorbed in our small intestine, and then it goes to our blood, and then it crosses the blood-brain barrier and goes to this dopamine neurons. So in the dopamine neurons, it is converted into dopamine, and then it is released here in the synaptic cleft and works in the dopamine receptors. So when we give dopamine or Levodopa to the patients, we are actually giving the precursor of dopamine. Sometimes instead of using the dopamine itself, we give agonists. So those are drugs that actually just mimic the effect. So they are these ones here, and they will work directly into those receptors without passing through the dopamine neuron here. So these drugs are, for instance, the pramipexole, ropinirole, rotigotine, bromocriptine. They will just mimic the effect here. We can also use drugs that will make this dopamine last longer. So for instance, we can use the CONT inhibitors like the tocapone, the entacapone, more recently the opicapone. And we can use also the MAO-B inhibitors, the selegiline and the rasagiline, which will actually make your own dopamine to last longer. So let's talk a little bit about the dopamine or levodopa. So levodopa is the main and most effective treatment for Parkinson's. It's usually used in combination with carbidopa, which helps levodopa to be intact while it's in the gut and in the blood, so it is actually capable of getting into the brain. So that's why when we buy carbidopa, levodopa, it comes in combination. So here in Canada, we have levodopa carbidopa, which is called Sinemet. We have the levodopa benzerazide. This is not very common here in Canada, but it's called Prolopa. Some countries tend to have this more available than carbidopa. And we have the slow release levodopa, which is also a combination of levodopa and carbidopa, which is the controlled release Sinemet. So dopamine can help with most of the Parkinson's symptoms. In terms of the motor symptoms, it particularly helps with bradykinesia, with stiffness, and in many patients it helps with the tremor, but not in everybody. So there is a lot of concern about when to start dopamine. So it's not uncommon that, as levodopa is the most effective treatment, that people want to save it for the future because they want to take something less strong, or because their symptoms is not as strong, or because are not as strong, or because they want to prevent some side effects. So there was a study done in 2013 that compared a population of patients in Italy and a population of patients in Ghana in Africa. And in Italy, patients had their treatment started within the first 3-4 years of symptoms. But in Ghana, because of the lack of healthcare providers and medication, most patients started on treatment 6 years after their disease. And what they found was that in patients that started levodopa earlier on, they had several years of very good response without having wearing off or off periods, without having dyskinesia. So this tended to start later. But in Ghana, when patients started levodopa, immediately, in less than a few months, they already stopped having this huge benefit from levodopa. So that means there is no reason why we should be postponing the introduction of levodopa if we feel that the symptoms are severe enough to start the treatment. So, and how do you take it? So it's important to know that the absorption of levodopa can be affected by high protein meals. So because of that, we usually recommend that patients start on levodopa 30 minutes before their meal, or sometimes 1 hour after they had a meal. So it's always better to take it on empty stomach, and especially if you're taking closer to your meal, then avoid having too much protein in the meal. Most patients with early Parkinson's, they don't see that difference if they take it with or without the meal, with or without the protein, because they absorb it very well and they have a long action of the medication. But over time, when the disease gets more severe, then patients really need to be on time and very regular and try to be compliant with taking their medications far away from their meals. So levodopa has a list of potential side effects. The most common ones that we see in clinical practice are nausea, upset stomach, low blood pressure, sleepiness, and hallucinations. So in Canada, we are lucky because we have domperidone, and domperidone is kind of an antagonist of levodopa in terms of blocking the nausea, the stomach upset, and the low blood pressure side effects. So we can prescribe that to our patients here. In the US, for instance, where I worked before, this wasn't available. So that can be very helpful. So, but when I said that people sometimes are afraid of taking levodopa is because they are worried with the motor complications. So the motor complications, so I really wanted to say it's Parkinson's disease motor complications. It's not called complications of levodopa therapy as people used to call it before, because now we know that these complications are caused by the duration of the disease instead of the doses and the duration of the levodopa therapy. So the good years of levodopa therapy, patients have a very good response. And then as disease progresses, they tend to develop these complications, which are the wearing off periods and also the levodopa-induced dyskinesia. So the motor fluctuations or the wearing off periods, they can be either a predictable wearing off, so when they can predict after a few hours the medication is wearing off, but sometimes that can happen in an unpredictable fashion, so the sudden offs. Sometimes some doses can actually fail, so patients, they take the dose and they don't feel the medication kicking in. And some patients, they can just be fluctuating between being on and being off. So when we say being on, that means having a good benefit from the medication, having good mobility, being able to function. When we say off is when the medication is actually not working anymore, then their Parkinson's symptoms tend to recur. So the patients feel slow, stiff, or they have more tremor. So it's important for people to recognize those symptoms to be able to report that to the doctor, because there is always something we can do to help when the medications wear off. But we need to understand the pattern. So we need to understand, does that happen in every dose? How long does the medication benefit last? So how long does it take then to the next dose to kick in? Sometimes patients have wearing off and then it's 1 hour before their next dose, then they have to wait, and then it takes 30 minutes for their next dose. So that means that during 1 hour and a half, they have really bothersome symptoms. In that case, we really need to maybe bring the doses closer to each other, or maybe add something to make that previous dose last longer and bridge that gap between the 2 doses of the medication. So it's really important that you try to monitor this, take note of each dose, the duration, how long it takes to kick in. Maybe you say, oh, in the morning it works really well, but then after I have my lunch, my medication doesn't work as well. So then we know maybe the protein is interfering. It's important to recognize those patterns. And what about the dyskinesia? So what are the dyskinesias? So dyskinesias are involuntary movements that happen usually in association with the medications, so usually after the patients take their doses, and it's usually described as either a jerking or wiggling, twitching, and rocking. So as you can see this in the picture, the patient is quite restless. So there are different types of dyskinesia. So dyskinesia can happen the most common one is in the peak of the levodopa dose. So you take the levodopa, then the level starts to go up in your brain. Then when you are at the peak, that's when most of the time patients get dyskinesia. But some people can also get it in the beginning of the dose and the end of the dose, what we call diphasic dyskinesia. And then some patients at the very end, when the medication wears off completely, then they have what we call dystonia, which is typically described as this curling of the toes that you can see here. And it's very common either during the night or first thing in the morning, because that's the time when patients have been away from their medications for their longest time. So when people have dyskinesia, we can reduce their levodopa dose if they are taking a very high dose, and that's causing bothersome dyskinesia. We can add a medication called amantadine. We can use other medications to spare the levodopa dose, and we can refer them for alternative treatments such as deep brain stimulation, for instance. So as I showed in the picture, in addition to use the use of the actual dopamine, we can also use those mimickers, the dopamine copycats or the dopamine agonists. These are the medications that will bypass the dopamine neuron and act directly in the dopamine receptors. They are usually not as strong in terms of relieving the symptoms, but they tend to last much longer. So they tend to last 8 hours. There is the patch that tend to last 24 hours. So it requires way less doses a day. So this can help with bradykinesia, can help with tremor, can help with stiffness. So most of the patients that the symptoms that can be helped by levodopa can also be helped by dopamine agonists. As I mentioned before, these are the pramipexole, the ropinirole, and the rotigotine. Those are the ones that we use more often right now. But these medications are also not free of adverse effects, so they can also cause nausea and drowsiness as levodopa can. But in some patients, these medications can cause sleep attacks. And this is very unique of this drug, so people can fall asleep during a conversation. They can fall asleep even when they are driving. So when we first start, we need to start on low doses and monitor the patients for those side effects. Not everybody has. I think some patients might have a genetic predisposition to get that particular side effect. So we need to monitor. And if that's the case, it's very common that we actually cannot use that drug in those patients. Some patients also present with hallucinations, and leg swelling, especially in the ankles, can happen usually when patients are taking higher doses. But one important thing that you need to be aware about the dopamine agonists is the impulse control disorders, which are uncontrollable desires to gamble, to shop, or to have sex. So sometimes this is mild and people can just monitor and be aware. But I have seen patients that had financial issues because they started gambling a lot and they were not aware the medication was causing that. So it's very important to quickly report to your doctor if you feel that any of those symptoms are happening with you. So in addition to the dopamine agonists, we have those two classes of medications that I mentioned that can make the levodopa last longer. So one of them is the MAO inhibitors, which are the selegiline and the razagiline. So this keeps your natural dopamine in the brain. And also, interestingly, some research studies have found that these medications may sometimes slow the progression of the disease. So we don't have very strong evidence for that, but there are some studies that find that patients take those medications, they have a slower progression. So the effect is also usually mild, but once again, these medications, they last a long time, so patients don't feel the wear off that they have with levodopa when they take them. So the selegiline is taken twice a day and the razagiline is taken once a day only, so it has a 24 hours benefit. So in terms of side effects, one of the most common ones is insomnia. So patients have a hard time to fall asleep if they take this too late, so we usually recommend it earlier. It can cause headaches, but one important thing is to know that these medications cannot be mixed with some types of food and also with some drugs used to treat depression. So if that is taken, then it can cause high blood pressure. So especially in foods containing high levels of tyramine, for instance, cured meat, aged cheese, wine, so that can interfere and cause sometimes very severe high blood pressure. So the other drugs in this family are the CONT inhibitors. They help the levodopa last longer, slowing how the body breaks down the dopamine. So it's usually offered only for patients when they have off periods, so when the medication is wearing off, and they need to be taken with the levodopa doses. So by itself, it doesn't work. It needs to be taken with each levodopa dose, and then it will increase the duration of that dose. So it usually can increase the on time by 1 hour a day. So there are two formulations. One is the Compton, which people take with their levodopa dose, or the Stalevo, which is a single capsule that has the levodopa, the carbidopa, and the entacapone all together. So in terms of side effects, some patients develop diarrhea with this drug. And as I mentioned about the sleep attacks, I think this is probably some predisposition that these particular patients have, and usually when they have it, they can't take it. But also this medication will increase the levels of levodopa in your system. So it may cause nausea, it may enhance the dyskinesia if patients have. So we have to monitor. But many patients do very well in terms of improving their off periods when we add this. So we have also the amantadine, which is used for the dyskinesia. It's usually taken 2 to 3 times a day. It doesn't have such a good effect in the bradykinesia and the tremor, but it can help on that too. But it's particularly helpful for fatigue in some patients. One of the things that we need to be aware is that amantadine can cause hallucinations, especially in older patients. So I usually start with low doses and gradually increase up to 2 or 3 times a day. And it can also cause some kind of purple discoloration in the legs that we call livedo reticularis. And finally, the anticholinergics. So these used to be used a lot in Parkinson's, but now that we have all those other options, it tends to be less used. So it's particularly effective for tremor control. We have in Canada 2 main drugs in that family, so the artane or the trihexyphenidyl and the benzotropine, which is called cogentin. And we try to avoid those drugs because they can cause memory issues, they can cause blurred vision, dry mouth, and constipation. So if someone already has a cognitive impairment, we should not be using anticholinergic drugs. So, and what about when we try to use all those strategies and symptoms are still severe or patients are developing a more advanced Parkinson's? So we also have options for that. So for instance, the surgical therapies, which we can do a lesional surgery, we call ablation, like a pallidotomy or a thalamotomy. Pallidotomy we use for dyskinesia, thalamotomy for tremor. We can use the deep brain stimulation, which are those electrodes inserted in the brain. And more recently, there are some experiments with the MRI guided focus ultrasound, which is a therapy already approved for essential tremor, and that's being studied for PD. So when you do the deep brain stimulation, which is the most common surgical approach for Parkinson's, we can target the thalamus, the globus pallidus, or the subthalamic nuclei. And each of these targets will actually be helpful for one of particular symptoms. So the surgery needs to be tailored for the patient's symptoms. So that's how it works. So usually there is an electrode implanted in the brain and a wire that comes down through under skin, through the neck, and there is a pacemaker placed in the chest. And that pacemaker will deliver the electrical pulses to treat the motor symptoms. There are different brands, different types of devices available in the market, each of them with their own features and indications. So, but who are the ideal candidates for deep brain stimulation? So for sure, first of all, patients need to have diagnosis of Parkinson's. They have tried the medications that we discussed before, but the symptoms are still not optimally controlled. They have off periods about 25% of their time, or they have very bothersome dyskinesia. So those would be the patients that we would think about those therapies. But then usually we prefer patients that are younger than 70 years old, that have Parkinson's disease for more than 4 or 5 years, so we really know that it's Parkinson's. They have good response to levodopa, good cognition, and no severe gait and balance problems, because as I mentioned, those can be worse after surgery. But we have to know that these procedures have a risk, so there is a risk of an infection that can be from the skin to the actual brain. There is a small risk of intracranial bleeding, so 1 to 5% of hemorrhagic stroke, and also problems with the battery, the device. The battery needs to be replaced every 5 years or so. In addition, we have, in addition to the DBS treatment, one of the other options that we have for advanced Parkinson's are the continuous medication infusion. So in other countries there, in addition to duodopa, they also have apomorphine, aliseride, which are other types of dopamine agonists. So the duodopa is actually a levodopa carbidopa intestinal gel that is delivered through a feeding tube that is placed in the stomach. So actually the feeding tube is placed in the stomach, but it goes directly to the small intestine, so it actually bypasses the stomach. Patients with Parkinson's tend to have slow gastric emptying. So in that case, we bypass that limitation and we go straight forward into the small intestine. So it usually, it's like this pump. So this is the pump that we can program, and then there is this cassette that contains the medication that usually needs to be replaced every day. So we usually refer patients for duodopa when they have severe off periods, when they tried the combination of different drugs that we discussed before. So they do respond very well to levodopa, but the problem is that it doesn't last long enough. So they need to be taking small doses of medications throughout the day. So preferably patients that do not have severe dementia or severe depression, but they can have a little bit of cognitive impairment. That's not a contraindication, and there are no age limit for duodopa therapy. So, but it also has some adverse effects. So these adverse effects usually happen in the first 2 weeks after the procedure. So patients can have abdominal pain, they can have constipation, nausea, they can have flatulence, they can have more hypotension. One of the most common things that we see is the actual infection around the tube, and sometimes that's treated with antibiotics, sometimes that needs to be replaced. In some people, the tube can also be clogged. So it's really important to know that the tube can only be used for the infusion of the medication and never for infusion of any type of food. So having this tube does not mean you're going to receive your meals through a feeding tube. That tube is only for the medication, so you can still eat completely normally. So, but the most important thing, in my opinion, is that we have to really see the person with Parkinson's as a whole, and there is not one magic treatment. It's a combination of a very healthy lifestyle with all these therapies that we have available. So it's really important that patients with Parkinson's eat healthy and keep themselves hydrated, that they have an active life, doing physical exercise, sleep well. It's important to engage in a support group and also engage in social and family events, that they have a physical therapist, especially to help with the balance and freezing, that they see a speech therapist when they have swallowing and speech difficulties, and that they take their medications, they are compliant. But all these pieces are equally important and will be helpful to make your quality of life much better. Thank you very much.
Thank you, Camilla, for such a great presentation. It's never a bad thing to always kind of revisit these understanding the motor symptoms and the process of Parkinson's, because you just never know who is new or anyone that is just looking to retouch their information. So thank you so much just for covering all the bases today for that. Does anyone have any questions for Camilla? We have one actually. Should the pramipexole, I believe is how you pronounce it, be taken at the same time that levodopa or at different times?
That's a very good question, actually. So